am Dr. R.D. Kharkar, consultant skin specialist practicing in Mumbai for the last 36 years. Today, I am going to talk about fungal infections, which has become a menace in our practice. More and more patients are visiting our clinic for fungal infections. Responses of fungal infections are not the way they used to be, and that is why it puts up a question to us whether we are dealing with fungal infections which are having resistance or clinical failure. So let's begin. What are fungal infections? Fungal infections are inclining towards epidemic proportions. 25% outpatient burden in dermatology is fungal infections. Families are getting involved like scabies, and treatment options are not as effective as before. So what's going wrong? Let's try to find out. So what is the current scenario of fungal infections today? We find that there's an exponential rise in the fungal infections today. The incidence of antifungal drug resistance is on the rise. This is something which is alarming. About 19% have been reported in one study, but we still are not having documented studies, and it has to be studied more. Now, changes in epidemiological pattern, we find that high temperature, high humidity are more common causes of the fungal infection increasing, and there's a lot of migration which occurs in cities which really increase the burden of fungal infections. Now, when we talk of fungal infections, we have the superficial fungal infections and the systemic fungal infections. Here, we are going to deal with the superficial fungal infections. We are going to understand what are the superficial fungal infections, how we are going to tackle, what are the drugs available, and how best we can use it. So, in the superficial fungal infections, we have got the classification as geophilic, which come from the soil, and that is M. gypsum. Zoophilic is from animals. You will be surprised that cats and dogs also can give M. canis and T. verrucosum, and anthrophilic is from humans. So far, we used to have a lot of cases of Tinea rubrum with us, but now we see Violaceium coming in, Mentagrophytes coming in. So these are the newer things which are coming in more. This is how the fungal infections look under the microscope when you see Trichophytum, Microsporum and Epidermo. Now there are different types of fungal infections which are being given names. When it is in the scalp, you call it Tinea capitis. In the beard, it is called Tinea barbae. Hand, it is called Tinea manum. Face, it is called Tinea facial. This you have to understand. More and more cases of facial fungal infections are on the rise. Tinea corporis is on the body, cruris is in the groins, pedis is on the legs, and angum is on the nails. So that's the way it goes. So changing clinical pattern, what is happening? Recurrence, relapse of fungal infections is higher frequency. Lesions are extensive. Now if you see the slide, you can see extensive lesions coming up on the body. Unusual atypical presentation. Number of lesions, morphology, site is all changing. Here if you see on the legs, you will feel that on first glance it is a contact allergy to slippers. But when you see it closely and diagnose, it's a chronic nature. There's an intractable itching, rapidly spreading in contacts through families, increased incidence in children, including immunocompetent individuals. Now how do we show you this? Now if you take a mother and child, here is a child and this is a mother. Mother has got the lesions on the face and the child has got it on the buttocks. Why do they look like this? Because of the use of steroid creams which are absolutely contraindicated in fungal infections. So this is how the infections come from mother to child and other family members also. Now I'll be showing you a slides where the whole fungal infections are now changing. Here you see the circinate pattern. Here you see extensive lesions on the buttock. Here you see extensive lesions in the groins. The Tinea cruris has gone into corporis, and this is under the breast, the commonest site in females for fungal infections. Now what is resistance versus clinical failure? Now resistance has been proved only in Candida albicans and Candida krusei against fluconazole. So this is the primary and secondary resistance proved. We still have not proved resistance in other cases. Clinical failure is a failure of an appropriate therapy for a certain indication to result in clinical response. So this is what we are seeing more. It's more of clinical failure than that. 18% resistance to various drugs only has been shown in Chennai in one of the studies. Now what are the reasons for all this? Climate and environment, we are seeing that the hot humid climate makes it more prone. Improper use of drugs. Doctors don't use drugs properly. Steroid cream abuse, this is the major concern as of today, and at a national level it has to be brought up. The steroid creams have to be banned, which are in combinations. They are the ones causing the most problem. Cost of treatment, this is another factor. If the whole family gets involved, the cost of treatment is very, very high. And then the last question comes in, generic versus branded. Now all said and done, the generic versions are supposed to be having the same medicine, but they do not deliver the result as the other branded medicines which are there. So why does that happen? Failure of therapy, if you see, the common reasons of failure of therapy are poor adherence to treatment, then you have reinfection from close relatives, misdiagnosis. Many a times the diagnosis is missed, and we are going to see them on slides how they are missed. Infection with uncommon species, as I said, drug resistance. Factors for clinical response, you can see in the patient, poor adherence of the drug, cost of treatment, immune status, and social stigma. They will not come to the doctor in the beginning, and that's how it increases. What are drug factors? Resistance to fungistatic drugs, frequency, cumulative dosing, absorption, distribution, all this matters, and drug-drug interactions with newer drugs coming in. We have to look into that also. And clinical factors are changing clinical presentations, misdiagnosis, underutilization of diagnostic tests, lack of counseling. This is becoming very important. It is highly important to counsel each and every patient of fungal infection. Lack of judicious prescription, non-prescription use of antifungal drugs. Now these are the diagnostic tests. What do? We don't go for the bigger test. We can just do a KOH mount and we can confirm the diagnosis. Now what is antifungal resistance? The problem is, like bacterial resistance, we have got a lot of studies, we can grow them easily. In fungus that is not the case, it becomes difficult to grow the fungus, and the resistance studies are also very limited and far-fetched. Now what are the drug factors? If you look at the treatment option, what are the drugs used for fungal infections? If you see the topicals, we have clotrimazole, miconazole, ibuprofen, sertaconazole, luliconazole, ketoconazole, oxyconazole and terbinafine. And the older treatment options are Whitfield's ointment and Castellani's paint, which we may have to use it in certain situations even now. Now what is happening here is, since we have got such a big array of treatment, we should know how to pick and choose and take the right treatment. Oral antifungals, we have got griseofulvin, terbinafine, itraconazole and fluconazole. Now what was the dose recommended? For griseofulvin, it was 500 milligrams per day for 28 days. Terbinafine was recommended as 250 milligrams for 7 days only. Itraconazole 200 milligrams for 8 days only, and fluconazole was 150 weekly, which doesn't work at all. So this is now gone. Now we have to revisit pharmacology. Why this is happening? Do not use oral drug topically, as it may cause resistance. You got fluconazole being given orally, and you got fluconazole cream and powders. We have to avoid that. Terbinafine is available as tablet, and we have got cream also. Avoid that. You have to use different combination. Increase the duration of treatment. If a drug does not work, you have to double the dose. Use multi-drug if resistance is there confirmed, and counseling becomes the mainstay of all treatment plans. Now this is what I was trying to tell you, that the pellets of itraconazole have to be very, very uniform. Many itraconazole brands provide non-uniform itraconazole pellets which do not ensure precise dosing, and this is why the patients do not respond to treatment. They also contain many sugar spheres with no drug. This is what causes a problem. Now, which is the best itraconazole capsule formulation? This is what are the recommendations given. You should have no sugar beads, and wood pulp based HPMC has to be used. Now, what is the treatment today? Griseofulvin, if you take, it is 500 mg per day for a minimum of 6 weeks. Terbinafine 250 mg, if you give daily, it is for 6 weeks. If you find that there is a resistance, you have to make it 250 BID for 6 weeks. Itraconazole is 200 mg for 3 weeks. It has to be given in a dose of 100 mg twice a day. Never give it at 200 mg. The 100 mg twice a day works the best. And fluconazole, if given, has to be given 150 mg either daily or alternate day for a minimum period of 6 weeks today. From 3 weeks it has come to 6 weeks. So how do we approach this? We have to see to it that we have to combat the fungal resistance. So selecting a proper drug, selecting a quality drug, the duration of treatment and the counseling of the patient will give us a very good situation. Treatment of tinea is today a catch-22 situation because there is a delayed response to treatment, no response to treatment. This is what we see. Large number of patients are from lower socioeconomic group. Now cost of treatment is exorbitant and rising. This is what makes it a big problem. And if we take the virgins which are a little low, they have the other impurities and they are not delivering the result as we want. Lack of both adherence and compliance to treatment is very, very important. Chronic nature of the infection has to be taken into account. Secondly, doctors do not give enough time for counseling. Now this is very important. If you don't tell the patient, we are going to look into it, what are the counseling factors. If we don't counsel them properly, the infections are going to come again and again. Side effects, the patients always dread side effects. So you have to always tell them to report to us immediately if they notice any of the side effects. Drug interactions, now due to comorbidities, patients are living long. they are taking blood pressure medicines, heart medicines, diabetes medicines, and they are known to interact with many of the antifungals, especially itraconazole. So we have to be careful for that. Patients are often maintained on multiple medicines, so the pill burden is very high and the drug interactions are also high, and this has to be explained to the patient. Now, higher dose and longer duration is becoming the therapy part. Now, if you see this slide, this is what I am trying to tell you. More and more infections are coming on the face, and if you treat them in 3 weeks with itraconazole, this is the result you get. This is something which is because of the steroid cream applied on the leg. If you give proper treatment for 3 to 6 weeks with itraconazole, this is the result you get. Extensive tinea lesions, 3 weeks of treatment with itraconazole or terbinafine will give you these results. Again, extensive lesions, you will see this, the patient is alright in 3 weeks, but continue for 6 weeks because the pigmentation over there will take a longer time to get better. Now, what is the management of treatment failure? If there is a treatment failure, if you see that the first line doesn't work, it is because of suboptimal doses or inappropriate doses, and you have to treat the proper infection and counsel. Now, what is counseling? Watch for decreased appetite with medicines. If there is a side effect, that could be one of the first results, nausea and vomiting. Treatment is for a long duration now, 6 weeks to it may go to 3 months. Do not stop treatment without asking the doctor. You have to apply soap on affected week every day. Wash with plain water. Do not apply Dettol or Savlon, that may irritate the skin. Ask other members of the family's roommates if they have similar complaints. You have to treat them. Wash clothes separately and in hot water. Towel has to be washed separately and in hot water. And the thick material pants like jeans have to be washed more frequently. This is very important. So what are the treatment pearls? Topical medicines have better pharmacokinetics than their systemic counterparts. Hence, combination is expected to have better mycological clearance than systemic alone. Combination should be from 2 different groups. The oral should not be the same as the topical. And drugs given for shorter durations with higher dose have less chance of developing resistance compared to lower dose. This is the study which is being carried on. Drug with keratophilic and lipophilic properties when given in higher dose will have a reservoir effect, and the treatment will be for a much better duration, and the remission will not be very soon. Combination of antifungals, if at all you have to do, you can combine itraconazole 100 mg BD with terbinafine 250 OD. You can combine terbinafine 250 OD with griseofulvin. You can combine itraconazole 100 BD with griseofulvin 250 mg BD. Now there is a study going on of initial terbinafine 250 twice a day for 2 weeks, followed by introduction of itraconazole 100 mg BD in the 3rd week for the next 4 weeks. This is being studied and it is giving good results. All the above regimens are on basics of anecdotal reports. Studies are in the process, and we have to wait for the final answer so we can get a standard regimen which can be used all throughout the country, and we should have no problems in treating fungal infections. So what are the take-home messages? National body should be formed only for dermatophytes. That has already been formed by the Indian Association of Dermatologists. All possible clinical experiences across the country should be shared. Special body should present this ticking time bomb to the Health Ministry through IADVL. Clinical research studies should be promoted. For example, multiple systemic drug combination therapy should be studied for toxic and efficacy. New drugs development targeting different sites should be used. Drugs to be prescribed by a dermatologist or a known doctor who has taken training in treating fungal infections. Updated guidelines are required and should reach every doctor in every nook and corner of the country. Cost of the antifungal systemic drugs should be made more affordable by the government. It has become global problem today, pan-endemic. There may be exchange of resistant fungi from different species. Especially India, we are facing the same problem. Because problem has not remained at a clinical level, community level, country level, it is getting into a bigger domain, and unless we work on a war footing, we may not be able to control and curtail the fungal infections. Solution for today's problem: patient should have compliance, take treatment properly, adhere to the drug regimen. Dermatologist should judiciously prescribe, counsel the patient, and preserve the efficacy of the existing drugs. If that is not done, we'll land up in a resistance problem and we'll get a major problem. Now I'm going to show you a few slides which will present to you in your clinic and how to manage them. Secondly, I'll be showing you certain complications which come in because of the treatments which are routinely used. You see case 1, it is Tinea cruris, but it has gone into what is called as incognito. Incognito is because of the steroid cream applied over there. So you have to immediately stop the steroid cream and start the regimens which I have told you. Topically, luliconazole, ibuproconazole and sertaconazole scores high above all other topical preparations today. Number two, if you see here, the color of the fungal infection has changed, and because of the topical cream you see it a little different. These are stretch marks which we usually get because of strong potent steroid combinations which are used by patients and many doctors. This practice has to stop. Again, here we see Tinea versicolor, the other form of fungal infection, which takes a longer duration up to 3 to 6 months to get all right, because they are not the white variety, they are the reddish variety which are coming in. If you see a single lesion on the forehead, sometimes we feel it could be leprosy, it could be other things. You will be surprised that in fungal infections we do get lesions coming like this and we have to treat it accordingly. This is again to show you the stretch marks which occur because of steroid induced creams. Now this is a different condition altogether. This is called as a larva migrans. Though it is annular, don't confuse every lesion to a fungal infection. This is treated with albendazole and it gets all right. Now this is to show you a boy who has got a fungal infection of the face, and he was given 3 weeks of a very potent steroid cream with antifungal, and he's already got Cushing's syndrome on the face or Cushingoid features. He's got a swelling on the face. Now this is what happens when you use steroid based creams. You get tinea incognito, which is highly complicated, and it takes minimum 6 weeks to alter. This slide I am showing you, if you see the band on the right side of the patient, on the right wrist, most of the college students are nowadays wearing bands. The fungus remains alive in these bands and it keeps on auto-infecting you. We have got religious threads which are tried there. So they need to be changed, because if you keep it for a long time, the fungus harbors there and you keep on getting the infection coming. Now this is another case where you get a linear lesion on the face and you feel it could be fungus. It was not. It was proved to be leprosy. So be careful on the face. Don't treat everything which looks round as a fungal infection. Here again you see tinea incognito, and you will see irritation which is called by Dettol or other such preparations which are used without diluting. Now this is something interesting. This is a 28-year-old girl. She is 2 months pregnant and she's got a fungal infection on the abdomen. So how will you treat her? Obviously oral treatments are ruled out. Here you have to give only topical. It will be in the form of either luliconazole or ibuprofen. You can give it twice a day and this will definitely give a relief coming. Oral medicines can be used only after the 3rd month, and the safest medicine shown today is terbinafine in a dose of 250 mg daily for 3 to 6 weeks. So in pregnancy after the 3rd month you can give the drug, not before. Now this is another condition which is called as a 2 feet 1 hand syndrome. This is a fungal infection where you see on the hands as well as on the nails. Now here if you treat, the nail involvement on the hands takes 3 months to recover. Nail involvement on the foot takes 6 months to recover. So how do you treat it? If you give itraconazole, it's 100 mg twice a day for 7 days, every month for the first 2 months in nail infection, and every month for 3 months for 7 days for the toe infection, along with application of nail lacquers. If you use fluconazole, it still works. It has to be 150 mg weekly for complete 24 weeks, and only then can you get good results coming. Now what is important topical here? The topicals are, you have got amorolfine which can be used, cycloperoxolamine can be used on the nails. They give very good results. So that's what you have to keep in mind. Now this is what happens in India in desperation. This is the lady who has put camphor and burnt her skin over there. So what happens, you have to first treat the burn and then treat the fungal infection. Now this is the last case which I will be talking. This lady came to me with a erythematous rash all over the face, and the doctor treating her was treating her for a sun allergy, and it started flaring up. Now here again you have to just pull the sari down and you will see a border, and you give itraconazole for 15 days and you have a smiling face coming to you. So the point is proper diagnosis, proper treatment, and the results are going to be phenomenal. So I hope this talk has given you some insights. You know how to treat fungal infections now, and definitely we have to have a broad base plan, treat for longer duration, but the bottom line would be counseling, counseling and counseling, and that should give us the best of results in fungal infections. Thank you.